to demonstrate benefit, but then in another study, you demonstrate harm on angiogenesis. And in this TIPS trial, you can see here there's a higher rate of BPD in patients with no PDA who received indomethacin. So again, there is real concern here that there are side effects. And I guess reflecting on that, given all the trials now, and we remember this, we didn't know that just routinely treating, like Benedictus and Oscar have shown, is harmful, potentially harmful, or potentially with no benefit. But actually, if you look back at all this evidence here, there is real examples of the side effects of these drugs. So we do need to really be judicious in our use of this. And I think that's the direction we're heading, is clearly we really need to choose the right population who will, their benefits will outweigh the potential and known harms of these drugs. So if you want to make a career out of systematic reviews, I think you've missed the boat. These are around 12, just 12, they're more, RCTs, systematic reviews, and they're all looking at when, how, timing, what of trying to close the duct or trying to reduce the effects of a PDA. And yet we are here where we are, where we still haven't really truly defined the population that may benefit. But it seems like a sobering reflection, but actually this is how evidence evolves. We need to do the studies, and I commend every single person and group who've led any of these RCTs or observational studies, and everyone who's performed these systematic reviews, because without this, we wouldn't have known. So this is a review of reviews, okay? So this is how in-depthly looked at this subject has been. And we show that there were side effects and harm from indomethacin, which is why we certainly don't use it in the UK. But there are potential benefits to IVH, for example. We know there's a trial going on SPIN by Shovik and Kanda. We know that now oral versus ibuprofen is more effective, high versus low dose is more effective in closing the duct, and neck is low of ibuprofen versus indomethacin. We wouldn't have known this if we hadn't done all these systematic reviews and these studies. So really commend everyone taking role in that. And particularly, really want to commend Samir and Willem, who led these incredible, excellent studies that have really shown that routinely treating the duct with ibuprofen, and we have to be very specific in how we describe these studies, showed no benefit. But that was using the parameters of assessing a duct mainly on diameter. Okay, and I think the reason why I was so keen to disseminate and this concept of reviewing evidence is I think it's really easy to read the abstracts of these studies and just conclude that we shouldn't be treating any duct. Okay, this is specifically very early, less than 72 hours, and specifically defining the duct by diameter mainly, although they did exclude pulmonary hypertension. And I'm sure you all know on the call the results of these two trials, that early treatment with ibuprofen was not associated with a lower risk of death or moderate or severe BPD in the baby Oscar, and Benedictus, which is a non-inferiority trial, showed that expected management was non-inferior to early ibuprofen. And they actually showed potential harm, increased BPD in the intervention group. Now, they didn't reach their trial sample size, but they had enough power to look at those specific questions. So really helpful in really demonstrating that we shouldn't be treating routinely the duct early on, just based on diameter, which was actually routine practice in many places around the world. So really helpful trials. And then this is a systematic review I'm sure you're familiar with, led by Shovik and his team, who included these studies. And again, with moderate to high evidence showing that there was no benefit of treating very early. So they obviously divided to very early, less than 72 hours, and early within 7 days. And they showed very similar results for the 7 days. And I'm going to go into these a bit more detail. I'm just giving you an overview of that Cochrane review here, which is there were no benefit, there was no difference in those primary outcomes listed here, mainly focusing on BPD and your neurodevelopment impairment as well. But they did find that very early, 72 hours or less of ibuprofen may lead to moderately increased harm in terms of mortality in your extreme preterm infants, which again is suggested from those trials that were discussed that, and I will show you some of the more recent trials, that there is concern and for specific populations. But again, we need to look at these evidence in terms of how they adjudicated a duct. So as I mentioned many times already, none of the trials were really stratified based on hemodynamic significance. Now, the Cochrane review says hemodynamic significant PDA, but they were very clear in their discussion, and this is where you have to read manuscripts really carefully in the fine print, that they do talk in the discussion in the Cochrane review about the limitations that these trials have been using, mainly duct size. But again, people only read the conclusions. So this is why it's so important to actually appraise the evidence. And it makes sense, doesn't it? The duct, how many of you on this call measure ductal size? I echo as well. I could make the duct a few millimeters difference easily, just by where you measure. Obviously, we should measure it according to protocol, but even cardiologists versus neonatologists measure the ducts at different places. Cardiologists want to get the biggest diameter because they want to put a device in. And so unless you really protocolize these assessments, you can really get large into their variability. And you know that the PDA can be of different shapes. I don't need to talk to the audience about the different phenotypes of PDAs, but it's not perfect. Okay, so if we're going to enroll babies based on that into trials, then we have a problem. But I will go on later on how we can solve it and why that is still challenging to address. Now, the other caution, which the Cochrane review absolutely goes into, is this high proportion of open label use in the control arm. Less than the Benedictus, and that was actually incredible how they had very little crossover. But if you do that, then it reduces the difference in the exposure between the groups and your ability to detect a difference. And if you look at many of the trials, they have huge amounts of crossover, up to sort of 40%. So you don't have this division in the two arms. And this comes down to clinician equipoise, doesn't it? And again, we discuss this a lot in the UK, is are you ready to hold fire and sit tight? Have you got your innate biases that will stop you from actually sticking to each arm? And that's a real issue, isn't it? And it's real life, it's real world. Okay, and that's why it's so hard sometimes to design and ensure RCTs run to their protocol. Then the other thing is there are variations in what we define as expectant. Okay, so some would even say that, I know certain authors have very strong views on this, that we should not even allow them to use diuretics. And we should definitely collect data on postnatal steroids as well, because all these are still part of management strategies. And you could argue they're not really conservative or expectant. So what is the definition of an expectant conservative arm is still very variable. Again, you have then the difference between the two groups is affected by what you define the control arm to be. And the early medical therapy, really importantly, as I've shown, does not equate to actually closing the duct. So when we ask the question, should we close the PDA? Well, that's probably the wrong question, because we know we're not closing the PDA all the time in all these with all these interventions that are medical. And maybe the right question is, is reducing that shunt beneficial? Particularly when we haven't found the holy grail that does close all ducts in 100% cases. And really important is that, particularly studies like the Benedictus, obviously excellent study, but it's done in countries where babies less than 24 weeks are very few numbers of those, if not none. And we need to be really thinking about whether the benefits might be different in the very extremely preterm babies less than 24 weeks, which there certainly has been a suggestion that it works differently. So where do we go from here? So the ultimate, just summarizing those thoughts, is there is clearly different hemodynamic significance of the PDA in each baby in front of you. And it's weighing up that for that baby in front of you, whether reducing that PDA shunt, the benefits of doing that will actually outweigh the potential the side effects of that particular intervention. And every intervention has its side effects. If you have medication, as I've gone on about it before, you can risk having problems with your gut. You can risk issues with your lungs potentially. We don't know the side effects of those COX inhibitors. If you go for an interventional catheter closure, we certainly have had complications. Okay, and some units even have had deaths. Obviously, it does rely on your level of unit expertise and that the centralization of those catheter closure and that service. So again, not completely generalizable to parts of the world that don't have that. Okay, so we are left with this issue of how do we balance that? The reasons here listed are to close. Okay. And I want to spend a little bit of time for that because if you want to really properly reduce pulmonary hemorrhage, okay, if that's your desire or IVH, your intervention needs to be really early within the first few days of life. So when you're thinking about should I close this or should I reduce the shunt, you really need to ask yourself, what am I trying to achieve here? And I don't think that we're all on the same page for this. Because if you really want to reduce IVH pulmonary hemorrhages, it needs to be really early. Or are you doing it just to reduce BPD when we are a bit uncertain about what the outcome BPD means anyway? Are you just trying to have later need for an interventional closure? Like, what is it that you're trying to achieve? And I'm not sure we absolutely on the same page for this as a neonatal community. So you can see how it's quite complex. If you're going to design a study, you need to know what you're trying to achieve. Okay, and we need to articulate these. So just to summarize, I think the trials done for very early closure clearly have shown that trying to close this duct with ibuprofen certainly is potentially harmful and should be abandoned. We shouldn't be doing any more studies, I think, where you're trying to routinely close a duct based on diameter. And then the criteria for selecting patients into PDA trials using diameter also should not be used. So we really need to think about alternative inclusion criteria and ways to identify these babies. And this is where I'm going to start to mention some of the more recent studies that have not been included in any of those Cochrane reviews. And this is a feasibility study. Okay, so this is Shovik's SMART-PDA trial. So congrats to him for getting that published recently. I don't know, my slides have gone a bit strange, but essentially they're less than 26 weeks and they screen these babies within 72 hours of birth. And they excluded those with congenital heart disease and other congenital anomalies, and they randomized within 72 hours. Now, what was this really clever, and it is smart, is what they were trying to do was have a selective early medical treatment strategy. So physiologically based, which seems like a huge amount of common sense, doesn't it? Versus not versus not treating. And they looked at using ibuprofen, but they also allowed paracetamol. And this was the criteria. And I'll go on to about all the different scoring systems later on towards the end of the talk. But this was in 72 hours, and they used clinical signs and echocardiographic parameters as well. So I won't go into this in detail, but you can see here it's quite pragmatic, quite real world. It's easy to use. Speaking to Shovik, this is really consensus of what's possible in a busy neonatal service of assessing PDA by echo. If you look at it, they have diameter, yes. And if you look at moderates, 1.5 to 2.5, but they have the other signs of pulmonary overcirculation, systemic hyperperfusion. They have the left atrium aortic ratio, transductal peak velocity, left ventricular output. I think that's one thing that we don't always measure, but has been shown to be quite predictive of a high volume shunt. And the diastolic flow pattern, the descending aorta, which I think is really quite consistent to be shown to be a strong predictor, and especially if it's retrograde flow. And so if you look at this on the echo, that sounds quite straightforward to do for most, even people who've just started to echo. And the problem, if you have more and more parameters and you have these variability in inter-observer measurements, you're going to get more and more really quite crazy values that don't agree anyway. And that's why Shovik, talking to him, wanted just to reduce it to a few. Then if you look at the clinical signs, you need to question yourself and go, are these the babies that I generally take to my grand round? I think that's a really good measure, isn't it? Are these the babies we're concerned of? And yes, if you look at severe, if they're in more than 50% and they're mechanically ventilated or not, you're still actually quite concerned about this baby. Okay, so it seems clinically it makes sense, and people signed up to it. And this is their recruitment. They had we randomized 104 babies, and I can show you the results here. Remember, this was a feasibility pilot study, and it was mainly to test the feasibility of actually implementing this early selective approach. So there's 7 centers, and they showed that they had they were able to do this, and they had high retention. They followed up these babies. They were able to do these early echoes. There were no safety concerns. And actually, if you look at the results, and if you look, they had 51 in the SMART arm, 53 in the control, very few protocol deviations. They managed to recruit 63% of the eligible babies, and they started treatment within 2 days for the treatment arm babies. And what they did show was that they had a reduction in treatment, actually. You would think, you would be afraid that if you introduce this, you'd think, oh my gosh, we're going to pick up more babies. But actually they didn't. They treated less babies with this approach. And so that's really quite encouraging. And we're certainly very keen in the UK to see if we can adopt this. They also found pulmonary hemorrhages were substantially reduced in the intervention arm. And that 85% used the win-win ratio, that the SMART strategy was more favorable. And this is from the paper here. You can see there's an 85% chance of those receiving intervention of having benefit. And just very briefly, the Bayesian win-win ratio is you essentially see per baby whether they would benefit from the treatment. And then you do this win ratio, or you call the number of wins versus number of losses. And for the SMART-PDA is 1.34, which was really gearing towards benefit for the SMART strategy. So that was a recent useful trial, just published in April this year, actually just 1 month after our review. And Shovik was on our review as well. Then the next trial that we saw come out recently is the Trio Kappa trial. And again, I put it in here because it's the very early category. And they were recruiting within 12 hours of birth, they were starting treatment. And this is so important to distinguish that this is a prophylactic intervention. Okay, so they didn't determine whether the ducts were hemodynamic significant. They didn't really even echo much at all. They just either gave it to all babies or placebo. Okay, and these were 23 to 28 weekers, impressive number of units across European countries, are really quite phenomenal. And they'd done some preliminary work already looking at the dosages of paracetamol or acetaminophen here. And the different gestations had different doses, as you can see here. And what did they find? Well, they found that, I think this is important, given that there's so little evidence for acetaminophen. Such an important study. They did show that if you're given acetaminophen, you're likely to have a higher probability of having a closed duct on day 7. And I think that's important. As you can see, it's not all, 100%, but certainly better than the placebo arm. I think that's important. You had less likelihood of needing rescue PDA treatment before day 7 if you had intervention. Very similar outcomes. But remember, this was, I'm not surprised here. It was there was no difference in survival without severe morbidities here. But remember, this is a prophylactic study. Now, really important was that there were some signs, indication of cholestasis increased in the intervention arm. And I think that's really important. We use so many drugs that we don't really know the effects on the other organs, and then we know they all have side effects. So really helpful to see this. And I know they've got follow-up studies planned as well. The take-home message for this is prophylactic paracetamol may reduce the need for reduced treatment. It doesn't improve survival. It's got a high rate of cholestasis. So essentially, paracetamol did close it up more often, but it didn't improve clinical outcomes. But what it didn't do, obviously, is actually only apply this to a certain select population. So we haven't answered the question of whether if we gave paracetamol to the population which we determined as high volume shunts who might benefit the most, whether that would actually make a difference. At the moment, we've put in a prophylactic approach. So hopefully there'll be future studies looking at that. We move on swiftly now to the later, so pharmacotherapy after first week. And for those in the room, that's certainly our approach. We're not really using interventions very early on in the UK. We generally are let's sit and see. And I think a lot of the world have moved to that approach where these trials, very early trials, unless you've got on-call people to comprehensively echo, it seems almost harmful to just treat if you're not sure this baby in front of you might benefit and is of high risk. So many people are now waiting to at least 7 days and after the first week. And there are many trials, actually, PDA Tolerate trial and this trial in from Korea, which had looked at these between 6 to 14 days. And more recently, I'm sure you're aware of the NRN trial, where it was around day 10 median age that they intervened. And so what did these trials show? So PDA Tolerate in 2019, it was actually, again, a feasibility study. But they showed that there was, what they did was they looked at babies less than 28 weeks. And for those with moderate to large PDAs, between 6 to 14 days, they would intervene with indomethacin, ibuprofen, or acetaminophen. And they also showed that the need for ligation or need for PDA follow-up here was no different. Okay, so there was no difference in the primary outcome. Now, remember, there was quite small numbers. There are some limitations to this study, and it wasn't a feasibility study. I want to just point that out. But there was a high degree of crossover, as you can see. And I think that's really important. You can see that receiving rescue treatment was like 48% in the control arm. So really important to know the limitations of these studies. And actually, if you look at the enrolled studies as well, they only recruited around 24% of the eligible infants. And that was due to equipoise or lack of physicians equipoise, okay, which is real world. And then it's important to also note that early treatment frequently failed to constrict the PDA in this study, and particularly for the extremely preterm babies. However, I think it's important to also note in the study that the median exposure to moderate to large PDAs was shorter in those that were exposed to the drug. Here you can see the dashed line. And I think that is still really worth noting. So it's almost these studies all give us some extra additional knowledge, okay, despite their limitations. This Korean study showed low efficacy of ibuprofen in 23 to 26 weeks. You can see the graph on the left is the 23 to 26 weekers, much higher incidence of PDA still being open despite the intervention. I think this is a very important secondary analysis of the PDA Tolerate study in that the moderate to large PDAs were associated with BPD, that outcome, particularly really when they were intubated for 10 days or more. So it seems like this 10 days or more, still intubated and still having a large duct, is a really poor prognostic marker. And I think this sort of 10-day mark is something that we should be really noteworthy of. So going into the NRN trial, though, because I know this has really garnered a lot of attention. And really congratulations to Matt and his team and the NRN for doing this phenomenal trial. It took them very long, 2018 to 2024, and they didn't recruit fully. It was a very hard trial to recruit to for all sorts of reasons, and they did have to close the study because they actually found that there was stopped because of trial for futility, but it was very difficult to recruit to anyway. So just summarizing this, published just literally the end of last year. And the aim was to determine whether expectant management compared with active pharmacological treatment using beyond just size of the PDA reduces the incidence of BPD or death. Okay. And importantly, they allowed, and it's a very pragmatically designed trial, they allowed paracetamol, ibuprofen, or indomethacin. Okay. And they had, in the end, 482 babies, 242 in the expectant, 240 in the active. They found no difference in primary outcome of death or BPD. However, really importantly, they found a high mortality rate in the active treatment arm. And that was after the 50% interim analysis, and that's why they stopped the trial. But importantly, they also found a high rate of infections in the intervention arm. Okay. So quite rightly, when these results were published, and I was there in Washington when it got presented at Hot Topics, again, a trial that agreed and was in line with Benedictus and in line with baby Oscar. And again, the question is, okay, so should we be closing any ducts now around day 10? You know, because this is a later on trial now, not the very early. Now, the question is, we need to look at how they assess the duct. Okay, so I'm sure for those who are very echo experts will look at this and still think there are still limitations. It's not very comprehensive, et cetera, but actually it's at least beyond the size of a duct. Okay, they do look at all these other echocardiographic and clinical features based on McNamara and Sayal's SADA criteria here, published in 2007. But we need to look back and think about, is this the population that we have equipoise in our unit? Okay, and this is where, again, you need to read beyond the abstract. And Matt is very clear when he presents it and when even in the discussion, that what they did do was they excluded those with cardiopulmonary compromise. Okay, because the investigators had no equipoise. Now, what does this mean? These are babies who are in a lot of oxygen, who have severe hypertension, end organ dysfunction, large PDA with severe clinical signs. Okay, they didn't include these because the physicians had no equipoise on these babies, and they would treat them and try and reduce the shunt or close the duct. So for us in the UK, that was actually the group that we have equipoise on. And I think it's important to recognize that. So just looking at this on a Venn diagram almost, as a researcher, you'd look at, okay, you've got all these babies with the PDA. Most of them will close spontaneously, 60-70% within the first couple of days. So yes, of course, I don't want to give my drug to those babies who won't benefit and close anyway, because they're going to get the side effects of drugs and nothing else. So what about the PDAs who don't close? Okay, and okay, which ones are symptomatic? They're eligible and went into the NRN trial, but those who are very, very sick didn't. Okay, and actually that's still the group that in the UK we haven't all agreed on what we should be doing. And so when we read the study, we need to remember the findings of this are not generalizable to all those infants who are very severely, well, we think might be affected by their PDA. And so the message is not to not close or not treat any PDAs. This is not what this trial has shown. We need to apply the findings of this trial to those babies that they recruited in the trial. So I hope that it makes it clear about that trial absolutely showed that among those babies who were, you know, symptomatic, okay, that sort of quite wellish, but has got this duct, yes, it does seem as if they may not benefit from their duct closing, and they may actually only just get the harmful effects of the medication. Okay, so again, that same message from Benedictus and Oscar. So even showing us more clearly that we really need to be very judicious in our use. But we still haven't fully absolutely selected that population yet, okay, because they didn't include those babies that we are still in equipoise on in the UK. And it'd be great to discuss at the end what you guys do in Australia. So just to summarize all those PDA trials, okay, you've got this timeline, you've got some trials done in the first 72 hours, you've got some trials done after 7 days, what we call early or for us late. What have we learned? I mean, I think I've just summarized what we've learned is we still need to identify which babies will truly benefit from treatment. And we can only do that if we do trials that are probably less pragmatic, I'm afraid to say. We've done the pragmatic trials, and it's shown that what we do pragmatically on the ground is potentially harmful. So we need to move away, I believe, to actually just accepting that we need to be more physiology-based, precision-based in terms of selecting our babies into future trials if we are to embark on any. Now, moving on swiftly, I'm just looking at time here. I want to mention the observational studies as well, because as we know, they've been conflicting with the trials, haven't they? And this is where the confusion lies sometimes. We've got studies done in the US, in France, in Ireland that have shown benefits and improved with targeted echo introduced and closing the ducts, or at least trying to attempt to close the ducts early. And this is the Reagan's paper in 2023. I'm sure you're all familiar with this in their introduction of hemodynamic screening for these extremely preterm babies. And you're probably very familiar with their protocol. I won't go into the details of time, but essentially they use the IWOC score, which is much more comprehensive. And you would, I brought this to my cardiologist and various groups, and not everyone thinks it's actually feasible to get 24-hour round the clock people to be able to do all these measurements. And there were concerns that also there's quite a variability if you measured these individually too. So, but they used the Iowa score and they found this reduction in their death and severe IVH after they introduced this. Similarly, on the converse, Gabriel and his team in Canada, great study. They looked at another observational study where they had 2 sites and they introduced this change to a non-interventional policy in the second site. And they looked at different epochs and they wanted to see what happened. And you can see here quite clearly on the right here, and the gray is that site 2 where they had a change in policy, that they had an increase in death and BPD afterwards. So it's almost conversely going to a non-interventional. What does that do? So both of those studies showed that there is potential benefits of having this targeted screening and these very high functioning centers with available echo expertise around the clock. Now, just summarizing it though, because I don't want, and this is in our paper, and it's really important to have a balance. There are some observational studies which have not shown benefit listed here, okay, up in the top. And if you want to know more, you can go to our paper and read the individual ones as well. And so it's important to acknowledge the limitations of observational studies. I won't go into detail, but there's confounding, isn't there? You can't ever have causality in any observational study. There's clearly selection bias, difference in center and practice variations. We know that they had difference in how they classified a hemodynamic PDA. Okay, and so it's not the gold standard of how we test an intervention, but I think it's really useful to show what is possible at a center level, what they can do clinically, but also generate hypotheses that we can test and the potential effect sizes as well. We all need this to design RCTs. Otherwise, we have no epidemiological data to design these. I've mentioned the limitations of the RCTs already. So where do we go from here? So I think it's important to clearly choose the right patient. I don't need to reiterate this again. Moderate, large size PDA does not all need intervention. And perhaps we should focus on the less than 26 weeks. In the paper, we'd say less than 28, but that's partly because we wanted to globally acknowledge that we aren't just the high-income countries, wanted to make sure that there would still be research amongst other populations as well around the world. But really, truly, in those centers which have available echo expertise, it's probably less than 26 weeks that will really benefit from an early intervention. We remain to test this in a very large RCT. I think the timing is so crucial. What are we trying to reduce? Is it IVH pulmonary hemorrhage? If it is, then it needs to be less than 24 hours or less than 72 hours. If it's later, is BPD the right outcome we're trying to reduce? That's still a question on its own. But if we do, we really need an assessment tool or some scoring or something that's actually validated, and I'll talk about that later on, that will best predict those that will not spontaneously close. Drugs. You can see here that none of the drugs are without its side effects, and we don't even know the dosing. Um, Although ibuprofen remains the most efficacious, we we know it's harmful in many ways and doesn't always work. Paracetamol, yeah, might be a potential now that we've seen that it actually does increase closure of the dog. We've had evidence now, but we need more longer term studies, and thankfully there are studies underway. We still haven't really answered the question of early catheter closure, and I think early catheter closure without prior exposure to NSAIDs would be the ideal trial. I know there are some authors who are interested in this, but it's not without its practical challenges, I'm sure, with having early catheter closure. And I want to mention very briefly catheter closure. There are many papers that have shown the safety of it and the fact that it's better than ligation, and the pivotal trials ongoing. Now, just to say that the protocol doesn't preclude them using medication. I think that they couldn't get that through ethics, but really important to have the answers of this trial where they're going to try and use catheter closure within 40 hours of randomization versus their supportive management. So really looking forward to this. And they're using the PDA scoring system. And their outcome measures is number of ventilatory support days as well, free of ventilation support days. So a nice continuous measure that hopefully they will reach their sample size so they can look at this. So where's the road going to? What should we do for the future? Now, I really think the first thing we do before we embark on any other further RCTs is like we need to pause. I think we should like ban any further RCTs until we can actually validate, develop a standardized and echocardiography or echo plus clinical scoring system that's actually validated. Now, I commend the SMART-PDA. I commend all the other scores that have been developed, but very few have actually been using a robust methodology to develop. Many have been expert consensus opinion, and there are many studies which have looked at what are the echo and clinical parameters. But I think if we're going to do this really robustly, we need to move beyond single centers developing these. And this is just a summary of all the different scores or assessments and the different primary purposes, the key components, and their setting that they developed in. And different studies use different ones. So I think it's no surprise that if we don't even have an inclusion criteria based on something consistent and actually evidence-based, that we are going to run into problems at interpreting those results. The Alka-Fish score is probably the most validated. They actually used logistic regression, and they did it in a really robust way, but they have tissue Doppler imaging. So again, it's how do we choose a score that's really accessible? So it's like that balance of being pragmatic, like that most people can do, but also very highly predictive. And I think the SMART-PDA was developed by consensus, and they've tested it, and it seems to at least not increase the number of being treated. It seems quite pragmatic, but again, we would like to see more robust methodology in validating that as well. But I think that would need to move probably beyond countries and have international collaboration. So it's a really lovely slide by Gabriel, the Neocardio Lab, which has all these different score systems, whichever you choose to use now on his website. I just wanted to point you out to that. We certainly use it quite a lot. Now, the second thing, which is quite contentious, is that we're going to do more RCTs. I think we probably do need to just, at least for proof of concept, to do them in centralized places where they have that skill and expertise, and where they also have that population of very little 24 weekers, less than 24 weekers. I know that's contentious. That might be not generalizable because you're just doing it in centers that have all the available expertise. But I think of almost scientifically, we need to show that concept. And then what we need to do is if we show that that's true, then we have to increase the training of neonatologists to do these comprehensive measurements. I think that is a pathway to impact. It's not going to be short. It needs a longer term view if we are going to do this robustly. We need to think about the different timing and an adaptive trial design. We can't just keep doing one trial at different time points and you'll need so many trials and it will just be completely impossible. It's be too expensive and also not helpful. So we need a much more clever way to run these trials with an adaptive design. And we need to find, if we can, better medical treatment. And this is just summarizing this in terms of looking at the outcomes that I mentioned before. And I would like to challenge you all to ask yourself, why do you treat the duct? Why do you, in your grand rounds, decide this baby in front? Why does it even need to discussion? And I think that is what should drive the future research questions. What outcomes are you trying to improve? Clearly more dosing regimes for those medications that we know very little about. And I'm glad to hear that there are desires to look at catheter closure and potentially even more early in those centers that can do it. At least that would be proof of concept of what happens when you actually eliminate the duct shunt, because we have not answered that. And we do need to define and standardize that expectant arm, as I said, and really try and stick to those protocols. And that probably means dealing with clinician equipoise a bit more openly. And we need longer term studies. And when you ask parents to co-develop our studies, they're often asking for longer term. They often say they don't really care about PDA. They care about their baby's and child's function later on in life. So we really need to be working closely with parents to design these future trials. And as I mentioned before, we've, I think, really eloquently shown by excellent researchers around the world that that pragmatic approach of just closing ducts in a non-selected population is not beneficial. Okay. And I think the next stage of our research journey is to accept we need a more comprehensive approach, selective. That would mean more difficult trials. We can't have just anybody do the echoes. It would need to be really specialist centers only. That's my thought anyway. And we need to be really robustly testing these assessment criteria before we embark on another RCT. And it will need international collaboration. So I'm not going to repeat these, but I hope that I articulated the population intervention control and outcomes that I think are for the future. I think the outcomes aspect is still really contentious. Obviously, survival without major morbidity is important, but we really need to question whether BPD is the right outcome. And certainly, at least we need to know the severity of BPD or the continuous measures like the pivotal trial is actually a really nice way to move to, or the door outcomes, that sort of hierarchical structure, the ordinal outcomes is something that many neonatologists are looking for in future trials. And we just need a better, cleverer way to conduct these trials and adaptive design. So better questions, better trials, better outcomes. We need to choose the right infant, the right treatment, right time, and right outcomes. So not too challenging for us as a neonatal community for the next 10 years. So I think really important, this is a slide I show my juniors, is I think please don't interpret the evidence that we should not treat any PDAs. And I am concerned because there are some centers where clinicians are just reading the abstracts and that's what they're telling their juniors. And that's not what the evidence shows. And you ask those authors of those papers, they also agree that's not what they're saying. It remains still uncertain whether eliminating or reducing your shunt using an intervention with high efficacy, less adverse effects in a more selected population would be beneficial. And I challenge us all across the world to try and answer this question together. And there, I'm going to stop my talk because I'm looking at time. Thank you very much.
Thanks, Cheryl. That was a great overview from, clearly a trialist looking at this data, but you started off with the question, is the PDA a problem? I really like that question. And then you added to it, do you believe the PDA is a problem. That's already where the first sort of bias starts. And then, of course, on the other end, we just have bad treatments. You took us to a bit of history. I really like those, the harm of treatments, the evidence for that was already in trials, 10, 20 years ago. And we just go like, no, no, let's just put that to the side and do more things. And then you showed us data, data, data. And then, when there is a systematic review of systematic reviews, then you already know
Yeah.
that, there is so much data out there. And rightfully so, you said, but read carefully. It's one, the abstracts, it's in the details, it's in the timing, it's in the dose, and who do they select? And those kind of things don't always pop up quite nicely if you read systematic reviews. You brought us a little bit of the issues with the original trials, which is actually feeding the systematic reviews. And then about, ask yourself, what is your goal for treatment? You brought it up a couple of times. I think that's really important for the clinician. What are you trying to do with that PDA treatment? Then you went to a couple of recent trials and showed sort of all the benefits and the things and what was sort of out there, the limitations. You summarized those trials, which was really nice in the summarized trial slide. But sort of almost next, it came to the cohort studies because the cohort studies tells you some more detail, which is just plainly not possible in a systematic review. So that's certainly something which we just need to acknowledge. And that yes, the randomized trial is certainly better for treatments of large groups, but if you select, and go deeper, you almost can't do a randomized trial and you come to cohorts. And the cohorts then are mostly by experts in the fields who have very comprehensive assessments. And you talked a little bit about that, should we go to more comprehensive assessments? I'm a hard yes. But actually, when you said about, your last couple of slides about now what, and you said, no, just stop. Let's just start from scratch. What is the PDA? Which one's significant? And how can we best assess it? And I totally, totally agree that that is a way to go before we go and do more trials of the same. All right, let's go to some questions which are popping up in the box. Um, I remember the
Yeah.
first question was a little bit out there. What about a term baby with a PDA? Do you do that differently?
Well, I think that the evidence for term babies with PDA is very sparse. So yeah, I mean, we would, yeah, completely evidence free for us. And very few would need treatment. I presume they would have other comorbidities, I suspect. I can't
So
remember
term
term
babies, often their PDA is actually necessary as a shunt to offload resistance and afterloads and different various systems. So often they don't need treatment. And if anything, if they get closer, you might have to want to open them. Madhu has a question here. Um, should we change the outcome from PDA closure to a normal physiological, shunt situation? Is there an acceptable level of left to right shunting? And is that then approved with sort of better outcomes?
Yeah, no, that is a good question. That is potential. That's open out to the jury, I think. It's a good suggestion.
Um, because you talked about those outcomes, he goes on with his questions, is what we are looking for, say in a late treatment, say day 10, and the baby's in 40, 50% oxygen, which was interestingly excluded from a lot of studies, and you then treat the PDA and you come down to, I don't know, less than 30%. Is that success, even though the PDA is not closed? What do you think?
So you're talking about if you've closed the PDA and you've gone from 50 to 30.
Now the PDA is open, you do some treatment, the PDA sort of constricts maybe a bit, or the baby just gets better. Is that a success, or what do we call that?
Yeah. So it's a good question. I think when we look at outcomes, we're trying to move towards more of a continuous outcome measure. And that would certainly, we've talked about having ventilatory days or non-invasive ventilatory days as a continuous outcome measure. And that would, I think the amount of oxygen you need will then influence what ventilation you're on. So that could be captured on that outcome. Is that what the question is? Talk about designs of studies.
I think so. They're also he relates. He wants to continue on, and which is basically the similar question, but Vignac about in these trials we often don't do just one course. We do a second course and a third course,
Yeah.
and that part is barely touched on in trial assessments and trial analysis. Just how much did we get? Is the
Mhm.
cumulative dose of these treatments more harmful? Have we looked at that? Is there some information in the trials about that?
Yeah, I believe there has been, I can't quote the actual papers, that there has been evidence to show cumulative dosing is more harmful. I can certainly send you some. But yeah, I think that's a really good question. In most of the trials would allow for multiple dosing, and whether or not in the future we design trials to allow that too. That is important in the design of future studies, especially when
And
we know that they're harmful.
yeah, Vinyak, you wanna unmute yourself because your question is very long. It's about PDA diameter. Yeah.
Uh, yeah, thanks, Kurt. Thanks, Cheryl, for wonderful talk. I was just curious about as you likely said, we've tried simplifying the inclusion criteria. All these the big, large studies that have been published, very well conducted beyond the inclusion
Mm,
criteria. But when it comes to defining these babies, if we just use the lone criteria of size, we probably are over treating babies when it comes to those which were included in the therapy arm. We in our center we use the similar score like criteria as Iowa, and when we looked at our practice for last 3 years, we found if we had just used one criteria, that is size, we would have treated nearly 35% more babies. um,
yeah,
and in our unit we just screen babies less than 26 weeks. We don't even consider 27, 28 weekers for routine
yeah.
screening. Yeah. So agree with you absolutely that we need a trial that will look at a better definition of the PDA. um,
Yeah, which is why I'm really encouraged by the SMART-PDA study. And the only parameter that might be a little bit less familiar is the LVO, but actually everything else is doable. And then the clinical criteria are common sense. I think most clinicians will accept that that's moderate or severe, the amount of oxygen urine and the mean airway pressure. So I am keen to try and we talked to Shovik of trying to implement smart PDA beyond Canada. And certainly we have interest in the UK because they've also showed that it actually reduced, as you said, if you just use the size, you'd be treating loads. But they showed even further that they had even less babies receive treatment when after they introduced smart PDA and they saw some benefits. So yeah, that was a feasibility,
Adding,
whether they,
yeah.
yeah,
I really, adding more criteria to basically what you said, stop. Let's just try to determine hemodynamic significance. There will be, of course, variations if you do it very early versus later. I think that's an important
yeah,
limitation when you're going to measure it. It will be easy, from day 5 to determine which baby has heart failure due to a
yeah,
PDA instead of just a PDA. But in the early phases, that definitely will require some more definition. Andy has a question. Would you like to explore the less than 72 hours? Andy, of course, is from the tech trial, and at the time, they had a high level of pulmonary hemorrhage. So I think his goal has always been, let's just do
yeah.
that. So that's generally where Andy comes from, and I totally agree. What do you think? If that's your goal, should we still do trials looking at that particular aspect?
Absolutely. I mean, trials are the gold standard way. And if your aim is to reduce pulmonary hemorrhage or IVH, then absolutely. But you still need an assessment criteria that is really well predictive of a hemodynamically significant shunt, if we can define that. So I do still think we need very early on trials, absolutely, to reduce IVH and pulmonary hemorrhage if that's your goal. But before we do that, we need to agree on assessment. Like, if you saw my slide of all the different scores, if you know, and all those authors I know, can you all agree on coming to consensus of one that's, you know, on balance, at least can be implemented more widely and scaled up across the world and be consistent?
Particularly the second question, can they be implemented with specialists? Yes. With high levels of ultrasound skills. Can you then apply that in many NICUs in the world? Who can get those skills? How much does it take to train them to get those skills? I think is a different question. And you know, your premise of this talk was about how can we get the best trial, how we can design the best trial. If anything, I think we should do way more measurements on these things and way more advanced. You know, skip the LAL ratio, do something proper. But you're right, that will limit, you know, usability after we found something. And that balance, I guess, in trials can be challenging.
Yeah. But I would challenge that though, Kurt. Having in my position as the BAPM honorary secretary and having sort of implemented lots of guidelines and developed them, you know, the evidence drives the guidelines and what's best practice. And then it's for us to then actually advocate for those resources to deliver best practice. So we need to show what's possible. And then the funding and the training should come afterwards. If we don't even show the evidence that that is what improves outcomes, then there will never be change. So I don't think it's impossible to have that training and to get everyone skilled up. You know, doing cranial ultrasound scanning is similar. We at the moment do them. It used to be obstetricians, or even it used to be neuroradiologists. In the UK, neonatologists do them all. So you know, I think change is possible, but we need to show the evidence that those resources would benefit, or that training will benefit if we scale it up.
Looked at some of the things we see in America where they want hemodynamic consultations by experts in the field, and they're training themselves up and providing funding for that training. That's a model I would love to have, but you know, our healthcare system wouldn't support that straight away.
Yeah, I know I've visited Iowa as well, and obviously co-authored that paper with Patrick. I don't personally think that model will ever work in the UK. We can't even fund our on-call clinical team, let alone a separate on-call hemodynamic team. I think we do need some assessment, echocardiographic assessments plus clinical, that the majority of jobbing neonatologists could pick up with some training.
They have to work and they have to show benefit.
Yeah, exactly. If once we show benefit, yeah. But I don't think this model of an on-call team will, as you say, work in most places around the world.
I agree.
So, which is why I think those observational studies are interesting, because it does show what's possible, what scientifically might be the hypothesis we need to be testing in different settings and in an RCT. And I think they're very beneficial.
It's 7 past. Cheryl, thanks so much for getting up early and giving us this wonderful overview. We really enjoyed this and the discussion. Hope to hear more from you, you know, in time when you actually have the now what sort of detailed and go, so this is what we're going to do. And I think the UK is a really good place because the models which come from the UK, I would agree, are more generalizable, particularly in the Australian healthcare system as well. So thanks again. Thanks for all of you for attending. And I hope to see you all next week when we have a session with Terry Inder about neonatal seizures, and as a tribute to Alistair Gunn, who passed away recently. Thanks, Cheryl.
Thank you.